Hello everyone, and welcome to the Academy for Eating Disorders webinar titled Integrating Psychotherapy and Medication in the Treatment of Eating Disorders with Dr. James Mitchell. My name is Bethany Blackwell. I am the Marketing and Communications Manager at the Academy for Eating Disorders and your moderator today. If you have any questions or concerns about this webinar, please feel free to reach out directly to me at AED headquarters via email at bblackwell@aedweb.org. Again, that's bblackwell@aedweb.org. You can also reach me by dialing 703-234-4120 in the U.S. and by adding a +1 outside the U.S. We have just a couple of housekeeping items before we get started. All participants are muted with the exception of Dr. Mitchell and myself. The webinar is scheduled for 90 minutes and is being recorded. It will be posted on the AED website shortly thereafter for AED members to download at their convenience 24 hours a day, 7 days a week. In just a few minutes, Dr. Mitchell will begin his presentation, after which he will answer questions from the audience. Please feel free to submit your questions to me during the presentation using the text box on the right-hand side of your screen, and I will read them to him when the question portion of the webinar begins. Dr. Mitchell, let's check your volume quickly. Please just say a few words, and if a couple of the participants can let me know if you can hear him clearly by sending a message in the text box I just mentioned, we will get started.
Well, hi, this is Jim Mitchell for the Integrating Pharmacotherapy and Psychotherapy in the Treatment of Eating Disorders webinar. That sound okay?
It sounds okay to me. If someone in the audience could let me know. Okay, great. Thank you for letting us know that the volume is good. So we'll get started. Let's begin by introducing Dr. Mitchell. For those who don't know him, he is the Chester Fritz Distinguished University Professor Emeritus at the University of North Dakota, Professor Emeritus from the University of North Dakota School of Medicine and Health Sciences, past president of the Eating Disorders Research Society, and a recipient of the EDRS Visionary Award for Research. He is also a past president of the Academy for Eating Disorders and a recipient of the AED Lifetime Achievement Award and the National Eating Disorder Prize Foundation Award for Research Excellence. He is also the author of more than 600 publications and author and editor of 18 books. So without further ado, Dr. Mitchell, the audience is yours.
Hi, everybody. Thanks for signing on, and look forward to your questions toward the end, so hopefully we'll have quite a few. That's the introductory slide. I also need to mention I have a conflict. I was a paid consultant to the pharmaceutical firm Shire, which markets a drug called Lisdexamfetamine, which is usually simplified into LDX. And I'll be mentioning that drug later when I talk about pharmacotherapy for binge eating disorders. So try to remember that I have a conflict around that medication. I think I'll mention it again. Okay. So in the DSM-5, as we all know, this is the way the eating disorders are arranged. They're now called feeding and eating disorders. The first three, anorexia and bulimia in particular, and then binge eating disorder, which was in DSM-4 as a disorder for further research in the appendix, are kind of the ones that have been around for quite a while. Pica and rumination disorder were also in the DSM-4, but they were classified as disorders of childhood here now. The third, avoidant restrictive eating disorder, or so-called ARFID, an abbreviation, is new and is generating a lot of interest. And I'm not sure the criteria are exactly pinned down right yet, but this was added in hopes of capturing a population that has really been ignored in the past. And I think it's going to be a very interesting thing to watch as the literature in this area develops. And the last two categories are, of course, the sort of wastebasket categories. Now, in this slide, I have highlighted the three disorders where combinations of pharmacotherapy and psychotherapy are commonly used. I'm not aware of any well done, compelling studies of the other eating disorders in terms of combinations of pharmacotherapy and psychotherapy. Most of the middle three, hyperrumination disorder and avoidant prescriptive, are treated with various kinds of psychotherapy paradigms, often using behavioral principles. So what we'll focus on today are anorexia nervosa, bulimia nervosa, and binge eating disorder. Now, in terms of psychotherapy, I've brought together a lot of data and to some extent opinion on this slide. And if you would look at categories from left to right in terms of the category and then the diagnosis. First of all, anorexia nervosa, there's not much of a literature in using self-help, guided self-help. Anorexia nervosa, I think, is generally considered not a particularly amenable condition with those sorts of interventions, given the intransigence of patients and their unlikely to actively participate in self-help intervention. Cognitive behavioral therapy is used. There are a number of forms that have been devised. Kathy Pike's, which was developed at Columbia, is the one that's perhaps most commonly used. It's a flexible form of CBT that was developed specifically for anorexia and seems to work well. IPT, or interpersonal therapy, has really not been used a lot for anorexia, neither is dialectic behavior therapy. For many people now, particularly in adolescence, family therapy is the treatment of choice, and we'll talk about this a little later on. This is the so-called Maudsley approach that was developed originally in Great Britain, now banned here in the United States. There's several other therapies that have been used for AN, and those are actually listed at the bottom: cognitive, psychodynamic, special supportive clinical management, and I'm sure there are others as well. And the database for these is limited but interesting. We'd have to say now for AN, probably the modal treatment for adolescents is family therapy. And I would suggest that for adults, Kathy Pike's cognitive behavioral therapy is probably as good as anything we have right now. Moving over to BN, a lot of these things have been used for BN. Actually, all of them have been.
Dr. Mitchell, sorry to interrupt you. Could you speak up just a little bit? Apparently you're cutting in and out with your sound.
Right? Sorry.
Yeah.
Okay. So each of these have been used in patients with bulimia nervosa, with the exception of the other anorexia therapies at the bottom. There's a fairly substantial literature now using self-help guidance with bulimia nervosa, and we'll talk a little bit about that. The CBT literature is the one that has the best empirical support at this point. There are a number of forms around. The type that people are most familiar with is usually Chris Fairbairn's enhanced CBT. Interpersonal therapy also has its advocates, and the research database here is also quite strong. Dialectic behavior therapy has research support as well, but the database here is quite. Also, there's a family therapy form of BN treatment that's been developed for adolescents. The research base for that is small but growing. So a number of things can be used for BN. Many people would say for adolescents right now, family therapy approach may be the treatment of choice, but for adults, probably cognitive behavioral therapy in one of its formats is probably the treatment of choice. BED, the literature is fairly analogous to the literature in BN, except family therapy is usually not an issue since BED patients tend to be considerably older when they come for therapy. Again, the research database here is most substantial for cognitive behavioral therapy. There are studies using self-help or guided self-help, interpersonal therapy, and dialectic behavior therapy. But again, as with BN, the CBT literature is strongest here, best developed for BED patients. Now, we'll talk a little bit about CBT or CBTE. This is, of course, a therapy that was originally devised by Aaron Beck, who's shown on the left. Beck was a pioneer in terms of developing a therapy that he was interested in studying empirically. He introduced a lot of methodology into psychotherapy research design, which was lacking up until that point. Beck now has retired. His daughter, Judy Beck, shown in the picture at the bottom, has taken over the Institute in Philadelphia, and that continues to do a lot of meaningful and also to be involved in studies at other sites. Chris Bergman's CBT manual is shown on the right, and probably is the manual a lot of people turn to BN, CBT for BN. This has been a personal therapy, which some of you may be familiar with and some of you probably use. This is a therapy that was developed by Myrna Weisslinger at Clarendon in New York, and it has a substantial database in depression and anxiety disorders and in eating disorders, particularly bulimia nervosa and to some extent BPD. This is very different than CBT for those of you who know it. Sometimes therapists who have been trained in a psychodynamic tradition find interpersonal therapy a bit more to their liking because it's a bit less prescriptive than CBT. Research database, as we said, is substantial here. Perhaps the greatest advocate of
Dr. Mitchell, sorry to interrupt again. Can you again speak up because apparently you still are cutting in and out?
Oh, really? I wonder if I
Yes.
can change something on my microphone. How's that?
Yeah, maybe if you hold it closer to you.
Okay. How's that?
I can hear.
Better? I'm sorry?
That works a little bit better for me, yeah.
Okay. Can you hear me now? Other people, Cheryl, Kel?
Yes, you sound better. Thank you.
Okay, thank you very much. So this on this slide is shown Denise Welfley, who's at Washington University in St. Louis. And the slide summarizes data from her first trial of CBT versus IBT in binge eating disorder, which was published quite a while ago now, 1999. And what Denise showed in this initial trial, and what's been replicated now in a number of other trials, is that both of these therapies are quite useful. And in this initial study, the results were well maintained at 4 months, 8 months, and 12 months. And that's been shown now in other studies as well. So IBT is a very viable alternative for treating BED and also for treating BN. DBT, as we said, is less well established. This is a course of therapy that was originally elaborated by Marshall Linehan in Washington. She originally used this approach for patients that were suicidal, and later it was broadened to include patients with severe personality disorders, particularly borderline personality disorder. Deb Schaefer, Christy Telch, and Eunice Chen have written a book which adopts a DBT therapy for bulimia nervosa and binge eating disorder. That book is available. It's well written, easily accessible. But as we said, the empirical literature using DBT remains limited, although something to consider in some patients, as we'll see. Now, this is the treatment manual for anorexia nervosa that was developed originally at the Maudsley in London, and the Maudsley is shown there on the slide. The Maudsley is a very famous hospital in the outskirts of London, and Gerald Russell, who used to run the Maudsley, was very interested in developing family therapy approaches for anorexia nervosa. Daniel Lagrange, who was originally from South Africa, studied with the group at the Maudsley before eventually coming to the United States, first at the University of Chicago, and now he's at the University of California in San Francisco. Jim Locke, who is at Stanford, and Daniel have formally manualized this approach, and the second edition of the manual is out now, is shown there. This is the approach that probably has the best research database now for the treatment of adolescents with anorexia nervosa. Now, this is an approach that seems somewhat irregular and different than most American approaches to family therapy. It's again one in which parents are basically instructed to take control of the adolescent early in treatment before eventually relinquishing control. So some therapists have found it a little hard to adjust to, but actually it works quite well and can be used very fruitfully in people's armamentarium. And a number of people now have been trained, and Jim and Daniel have made it a point to make workshops available and such things as that to disseminate this. So that's the Maudsley approach. Now, as we mentioned earlier, there are a number of other self-help and assisted self-help approaches. These have been utilized primarily with bulimia nervosa and binge eating disorder. The self-help manual that probably is used the most is Chris Fairbairn's second edition of Overcoming Binge Eating, shown on the left. Another very useful manual is the second one from the left by Glenn Waller and colleagues in London. And it's also very well written and very accessible. The third is a book by Janet Leitner and Terry Wilson, which summarizes self-help approaches. It's about 10 years old now, so it's a little dated. The Glenn Waller and the Chris Fairbairn are probably the two that I would recommend consider using in supervised self-help. Now, what's the literature like with self-help? Well, until fairly recently, it was not particularly well developed. A lot of the early studies were not randomized, had inadequate control groups, small sample sizes. Sometimes the assessments were not well standardized. Follow-ups were brief. This is changing quickly and dramatically. And for those of you who are interested, there was an excellent review called Guided Self-Help for Eating Disorders, a systematic review and meta-analysis, that meta-regression actually, that was published in the European Eating Disorders Review a few months ago. And if you're interested in self-help approaches, I would highly recommend this article, and you should be able to download it from PubMed or some other website. I also want to mention very briefly technology assisted in secondary treatment areas. Again, this is an area of very rapid development. People have been extremely interested in finding ways to extend therapy beyond a simple therapy hour by using various kinds of technology-assisted devices. And I've shown a list of these, which we don't have time to go to in detail. The three that have stars by them are ones where there have been randomized trials in patients with BN and or BED. And so this is an area, again, that's moving along very quickly, and I think is going to have much broader impact in the next couple of years. The technology is there. It's a matter of adapting it to working with this patient group and it's moving very quickly. Now, one of the areas of great interest is being able to predict which patients will respond to which treatment, since there are several alternatives that we've mentioned. The very good review of this is a little out of date now. It was published in 2015 in the International Journal of Eating Disorders, called Predictors of Treatment Outcome in Individuals with Eating Disorders, a systematic review and meta-analysis. And there's obviously a great deal of interest in being able to say this or that patient will probably do best with this or that approach. Again, this is a developing literature. One of the problems is to really look at predictors and moderators of therapy response requires rather large sample sizes, and that's often a problem in terms of the expense involved in research. But nonetheless, this is a developing area, and I recommend this article to you if you haven't read it. Okay, this is my first joke slide, because I'm moving on now to psychopharmacology. These people say that their psychopharmacologist is a genius, and he seems to be giving them something that they find very reinforcing, although I have no idea what it is. So, in terms of pharmacotherapy and using pharmacotherapy in combination with psychotherapy, we're going to concentrate on BN and BED. The reason being that there's really no established drug therapy for anorexia nervosa. People have certainly looked. They have looked long and hard to try to find something that will be effective for anorexia nervosa. And quite frankly, the literature is certainly mixed. There's some data that suggests some of the atypical antipsychotics may help a bit with weight gain, but the literature is really not very well developed. And in randomized trials, there's minimal, if any, effect. So pharmacotherapy, unfortunately, appears to have a very modest effect, if any, in anorexia nervosa. And so we rely very much on other treatments like inpatient or partial, residential, or outpatient. Now, shifting to talking about binge eating, and this could be in the context of bulimia nervosa or in the context of anorexia, BED, many of the traditional antidepressants will suppress binge eating. That includes the tricyclic antidepressants, the SSRIs like fluoxetine, and the SNRIs, or serotonin norepinephrine reuptake inhibitors, and the more pure norepinephrine reuptake inhibitors. All of these are effective in suppressing binge eating, although the only one that's FDA approved now for bulimia is fluoxetine. Now, these are very good for binge eating, but they have modest or no effect on weight. And so, with the exception of atomoxetine and duloxetine, which have a very modest effect. So, these are very useful drugs in terms of suppressing binge eating, but if you're also dealing with obesity, which would happen most commonly in the context of BED, these may not be the best available agents. And because of the fact that the tricyclics have more side effects than these other classes of drugs, I've shown them here in smaller form. Imipramine, desipramine, and the other traditional tricyclics work, but they're difficult to use, and they have lots of side effects, and because of that, they're really not used much now at all. Probably preferentially the SSRIs or SNRIs or NRIs should be used if you're looking for a drug for binge eating that doesn't have any impact or substantial impact on weight. Now, there are also two anti-epileptic drugs and one new drug, Lisdexamfetamine, that I mentioned before, which do have effects on binge eating and also suppress weight. Now, none of these are marketed for obesity. Topiramate and zonisamide are anti-epileptic drugs that were found as a side effect to suppress binge eating and also to cause weight loss. Lisdexamfetamine is FDA approved for binge eating disorder, but not for obesity. However, it causes weight loss, although they didn't go for an obesity indication. So all three of these drugs can be used in situations where you're desiring both an effect on binge eating and an effect on weight. The problem is that particularly topiramate and zonisamide are difficult drugs to use, and we'll talk about that as we move along. Now, if we look at these two anti-epileptics, first of all, they have a number of side effects and toxicity. One is what are called paresthesias. Paresthesias are a sense of numbness and tingling in certain body areas. With topiramate and zonisamide, paresthesias happen very commonly. I'd suggest they happen probably in 60+% of patients. They most commonly involve the face, most commonly the perioral region around the mouth. So the majority of patients in my experience who are treated with those will report numbness and tingling about their mouth. And many of them also report that beverages taste a little different, particularly fizzy kinds of drinks. And some patients find this rather annoying. There are other side effects that are shown there as well. The other major side effect of topiramate and zonisamide, which in terms of health indications is actually more severe, are cognitive side effects. Topiramate, which is most commonly used of these two, causes problems with attention, with memory, and with word finding ability. And most patients who experience these cognitive side effects have relatively poor insight into the problem. A clinical example would be a patient I had in the past who came in, who we had taken off topiramate, who reported that her coworkers had told her that she was very different now and that her memory was much better. And she was unaware that she had an impaired memory on the drug. So these can be minimized if you start at a very low dose. For example, using topiramate as an example, like 25 milligrams a day, and then increasing very slowly up to a maximum of 200 milligrams a day. This will minimize the likelihood of cognitive side effects, but they may still develop. Fortunately, they resolve when the drugs are discontinued. So if you're interested in using these, they're used commonly for obesity and in binge eating disorder accompanied by obesity. But they're tricky to use, and not all patients will tolerate them very well. Lisdexamfetamine, the other drug we mentioned, is actually structurally related to D-amphetamine, but it's an odd drug in that it is not metabolized as most drugs are in the liver or the kidney, and instead is metabolized in red blood cells. So when you take lisdexamfetamine, you're actually taking a prodrug that is then absorbed and in red blood cells is turned into D-amphetamine. So what this means is that as opposed to most amphetamines, which peak very quickly after they're administered, particularly IV, but certainly orally as well, this drug actually has a very gradual onset of action over a period of hours. That seems to minimize the abuse liability. In other words, patients don't find this drug quite as reinforcing as amphetamines that peak very early. So it is an amphetamine. It's a scheduled compound and should not be used in patients who have problems with substance abuse or have had problems with substance abuse. However, the safety profile in general is good, and as we said, the abuse liability appears to be quite small compared to other amphetamines. Now, this is a paper that I think is still in press, although it should be coming out shortly if it hasn't. A study by Hudson et al., where they looked at lisdexamfetamine versus placebo when both were used over the course of 6 months. Everybody was started on lisdexamfetamine, and then after 12 weeks, they were randomly assigned to be switched to placebo or to stay on the parent drug, lisdexamfetamine. And these are the relapse rates. As you can see, the relapse rate with lisdexamfetamine was about 4%, and the relapse rate with placebo was about, almost 40%. Now, the good news is that lisdexamfetamine performed better as a maintenance drug than the placebo. But the other good news is that about 2/3 of the patients who were changed to placebo did not relapse. So this suggests that some patients who have an initial response to lisdexamfetamine will do fine once the drug is discontinued later on. So this is a very interesting report. I suggest you read it. I think you can find it online now in JAMA Psychiatry. LDX does have side effects. This is lisdexamfetamine. It decreases appetite, which is good in this context. It can cause headache, irritability, insomnia like other amphetamines. And we said it should not be used in people with substance abuse histories. Now, there are also some combinations that are used with weight loss effects in binge eating disorder. Topiramate, the antiepileptic we discussed before, is sometimes used with phentermine, which is a very weak amphetamine, or with the antidepressant drug bupropion. Zonisamide, by analogy, is also at times administered with phentermine or bupropion. Now, there's actually a commercial product available which is a combination of topiramate and phentermine. It's a marketed compound. Hello? It's a marketed compound for obesity. However, both of these drugs are available generically, and there's no reason to prescribe that drug because you can prescribe these drugs cheaper if you prescribe the generic. Also, you have more flexibility in the dosing. Now, phentermine is an interesting drug, and it's regarded very differently in the United States by different state medical boards. For example, I'm in Minnesota, and phentermine is something we can use here very liberally. However, in other states, medical boards are not happy with physicians prescribing phentermine, given that it's a weak amphetamine. I was in Ohio recently, and in Ohio, the medical board is very intolerant of physicians who prescribe this drug. So depending on where you live, if you're in the United States, you need to know something about the attitude of physicians that of the boards that police practitioners. The third combination that's used is the antidepressant bupropion and the drug naltrexone. Naltrexone is a narcotic antagonist, and bupropion will cause weight loss and also is a good drug for depression, but it also slightly increases one opioid that works against weight loss, and naltrexone blocks. There also is a drug that's marketed of the combination of bupropion and naltrexone, but again, the generics are available. They're generally cheaper, and you have more dosage flexibility. So again, if I were going to use the combination of bupropion and naltrexone, I would probably prescribe the generic, although in that case I would check with pharmacies to see, because sometimes the commercial product is actually priced reasonably. But in general, prescribing generics is going to save your patients quite a bit of money. Bupropion has a side effect that we well know of in bulimia nervosa, in that it can cause seizures. And if you read the package label for bupropion, it warns against using the drug in women with bulimia. However, in people recovered from bulimia, or in people with binge eating disorder, or at lower doses, there isn't much evidence that bupropion actually causes seizures very frequently. It's related to rapid onset versus delayed onset forms of the disorder, and is usually seen at high doses in the rapid onset. So generally, bupropion and naltrexone are well tolerated. However, bupropion should not be used, particularly in high doses, in people with bulimia nervosa. And the combination again is used both for bulimia, for weight loss and also to suppress binge eating. Now, our purpose today is not really to focus on obesity, but when we're talking about binge eating disorder, which as we know now is the most common eating disorder, there's a very close association between binge eating disorder and obesity. And so I'm going to say a little bit about obesity. This is looking at BMI relative risk for mortality in women on the left and men on the right in various age groups. And what you see here is that mortality is quite low at a BMI around 21 to 25 to 27. But then the mortality rate in all three of these age groups and in both sexes starts to go up. And so when you get people with a BMI of 33 or 37 or 41, all of which are in the obesity range, the likelihood of increased mortality rate is substantial. And obesity now has surpassed smoking as the #1 preventable cause of premature mortality. So if you're working with eating disorders patients and you see BED, you need to think in terms not just of binge eating, but also of the obesity. And if obesity is present, you need to think about what kind of an approach you can take that will address that. For example, if we look at someone with a BED who has a BMI, let's say, of 41, where's the fire? Is the fire the binge eating? I would say no. I'd say the fire is the obesity. And that's what really formally needs to be addressed. So if you If you prescribe medication, you need to think about addressing that. If you don't, if you do mainly psychotherapy, you may want to affiliate with someone who is knowledgeable about drug treatments for elevated BMI. My second obesity slide, and I won't drone on about this, but obesity can hurt us in lots of different ways. The three we think about the most are type 2 diabetes, which is now becoming an epidemic, hypertension, and dyslipidemia, or lipid problems. Also now we know that obesity is associated independently with mood problems, liver disease, reproductive disorders, and heart disease. Also, there are 17 forms of cancer now that have been shown to be linked to obesity. So there are lots of reasons why, if someone is obese, we need to seriously consider what can be done about that. I mentioned diabetes as my third obesity slide. This is looking at the risk of type 2 obesity as a function of BMI. And as you can see, as our BMI goes up above 25, the risk of type 2 diabetes starts going up dramatically. And type 2 diabetes is not a benign disorder. It affects us in lots of adverse ways, particularly damaging both microvascular structures, or ones that are innervated with very small arteries, and macrovascular structures, or very big arteries like the aorta. So we need to think very seriously about what type 2 diabetes is doing to our patients. Also, when we work with BED, we need to consider bariatric surgery. We know that BED increases with the severity of BMI. And when we encounter someone with a BMI that's more than 40, or someone with a BMI more than 35, who has comorbidities like hypertension, diabetes, and dyslipidemia, and most of those patients will have at least one of those, we need to think about bariatric surgery. The likelihood that someone with a BMI of 40 or 35 is going to lose substantial amounts of weight without bariatric surgery is very low. And bariatric surgery now has been refined into very safe procedures that have good long-term outcomes. So again, when we are working with BED patients at a very high BMI, we need to consider bariatric surgery referral. Now, there are two types of bariatric surgery that are widely used in the United States now, and actually worldwide. One is Roux-en-Y gastric bypass, which is shown here, which involves several steps, including creating a pouch in the stomach and swinging up a loop of bowel, which causes the food to bypass part of the bowel. This has now been used for more than 30 years. The newer procedure, which has now been around about 10 years, is the sleeve gastrectomy, where the stomach is turned into a sleeve, which was originally used as part of a two-stage procedure, but now works quite well on its own. Sleeve gastrectomy works almost as well as Roux-en-Y, but not quite as well. And so in patients who have bad problems with diabetes, they're more severely obese, Roux-en-Y gastric bypass is probably still the preferred procedure. I skipped a slide in there, but that's okay. This is my second joke slide. This was a treatment program we were doing up in Fargo when I was there on the left, a binge eating disorder treatment program, which the newspaper saw fit to pair with an all-you-can-eat fajita ad from Mexican Village. This actually got quite a bit of publicity and made it on the Jay Leno show. We caught a lot of adverse comments for this. Now, there are a number of ED practice guidelines that are out there, and most of them are available free on the web, and we don't have time to go through them in detail. The Agency for Healthcare Research and Quality, or AHRQ, are available free on the web. So are the NICE guidelines, or NIC guidelines from Great Britain, and version 2 of the ED NICE guidelines were just recently published. Third is the thing called the Eisenberg Center for Clinical Decisions and Communication Science at Baylor, which is also sponsored by NIH, and those are available. The last two, the Australian-New Zealand Practice Guidelines and the American Psychiatric Association Guidelines, are both fairly broad and not terribly specific. So I would be much more likely to rely on the first three sets of these guidelines if you're looking for guidance. This, for example, would be the AHR guidelines, is just as an example, number 160, which is for BED. And they show there what the literature review shows. Basically that second generation antidepressants, topiramate, lisdexamfetamine, all are good in improving binge eating and binge eating days. Topiramate and lisdexamfetamine, and that has slipped down a bit, but they're both good in terms of decreasing weight. This is the NICE guidelines for psychological treatment of BED as another example. And notice, if you would, that they recommend considering starting with an evidence-based self-help program. And that's something I would recommend. Evidence-based self-help for BED actually does quite well for a sizable subgroup of patients. They go on and then recommend a CBT for BED as the one with a grade A, and IPT as a grade B, and maybe DBT as a grade B. But they suggest considering evidence-based self-help to start, and then if patients need full interventions, CBT. So I'm going to make specific recommendations now about what I would do with various drug psychotherapy combinations based on this literature that I just reviewed. First of all, if we have an adolescent with anorexia nervosa, I think the treatment of choice now is the Maudsley family therapy approach. What about medication? And then for adults, we list these as alternatives. And the one I recommended earlier was cognitive behavioral therapy, the form that was developed by Kathy Pike at Columbia. Now, if somebody is not responding with anorexia nervosa, should we add a serotonin reuptake inhibitor? Actually, there aren't good data to support that. There isn't any evidence that SSRIs actually improve weight gain or ameliorate psychopathology in AN patients. People do it sometimes, but the research database is not compelling. What about adding atypical antipsychotics like olanzapine or aripiprazole or risperidone? Some people do this. There is one study suggesting that olanzapine may improve the rate of weight gain slightly, but the evidence overall is modest at best, not convincing. So there really isn't convincing evidence of of using atypical antipsychotics, unfortunately. What about relapse prevention? Again, some people try to use SSRIs. There isn't good evidence that they actually increase the rate of relapse prevention. So unfortunately, the situation with anorexia nervosa in pharmacotherapy is not very encouraging. And that's the way it is, and maybe new things are going to come along, hopefully. But right now, the mainstays of therapy are non-medication based. Now, what about BN and BED? I've summarized here some information about the number of trained practitioners and the difficulty in learning to deliver these things. First of all, proven psychotherapies. This would be like cognitive behavioral therapy, the enhanced version by Fair. Are there many trained practitioners? Well, there aren't a lot. And we know that people who are actually well-schooled in proven psychotherapies for BN and BED are not commonly seen. Also, learning these therapies well is difficult. It's not an easy task. And because of that, many practitioners who treat these patients are not really using an empirically validated treatment. What about self-help? Well, supervised self-help could be quite common, and it's not difficult to learn. For example, using supervised self-help with bulimia nervosa, you can start with a full session, but then have 20-minute sessions every few weeks, and have the patient read the self-help manual you're using and concentrate on having them dedicated the necessary time to learn that. How about pharmacotherapies? Well, they're fairly easy to learn to use, and because of that, they're commonly available. So overall, when we're thinking about using drugs versus psychotherapy versus the combination, I think we need to think about whether or not we have psychotherapists available who can deliver these therapies. In many situations, we should think about starting the supervised self-help and or using proven pharmacotherapies. And some of you may disagree with that, and I'd love to hear you talk about that in the question and answer session. So I would suggest that for a lot of patients with BN and BED, a step care approach is useful. To start with medication plus supervised self-help. If that works, great. Go on to maintenance therapy. If it doesn't work, then go on to a structured form of full psychotherapy. So in BN, as I just said, supervised self-help, or for those of you who are CBTers and want to start with that so much to support that. Also, I think we should consider using medications in BN, particularly in patients who don't respond well or quickly to CBT. I would not use the tricyclics or the anti-epileptics since they have too many side effects. In BN with depression, again, I would be particularly likely to also prescribe an SSRI or an SNRI in addition to supervised self-help or CBT. In someone with an anxiety disorder like panic, I would avoid using SNRIs, which can increase anxiety. Instead, I would use supervised self-help and or CBT and or IPT if you're an IP tutor, and then think about adding an SSRI for the panic if you need medication. For BED, not complicated by overweight or obesity, again, I would consider supervised self-help and or CBT and or IPT. and also consider, particularly in treatment-resistant patients, adding LDX, a serotonin reuptake inhibitor such as fluoxetine, or a serotonin norepinephrine reuptake inhibitor. If the BED is complicated by depression, I would avoid again tricyclics and anti-epileptics and instead use an SSRI or an SNRI. And if the patient again has an anxiety disorder, I would avoid an SNRI, but instead, if I was going to use medication, I would add an SSRI. Clearly, if supervised self-help and or meds are unsuccessful, then it's time to move on and do a full-bore CBT or IPT if the patient's not significantly overweight or obese. What about if the patient is significantly overweight or obese? I would suggest again that something like supervised self-help is the first step, or CBT or IPT are indicated. I also think you need to address the weight, and you can do that by using LDX or the combination of topiramate and phentermine, or the combination of bupropion and naltrexone. And if you use those combinations, I would start one and then add the second drug depending on the tolerance and response. However, if we have someone who's quite obese with a BMI over 35 or 40 and they have medical comorbidities, then I think we need to consider referral for a bariatric surgery evaluation. BED is not a contraindication to bariatric surgery. Some patients will reestablish binge eating after bariatric surgery, usually in the form of what's called loss of control eating, but some patients don't. They do just fine. And because of that, and given these severe complications associated with these very high BMIs, I would say that bariatric surgery should be considered. Okay, we're going to work through some cases now, and then we'll stop and have questions or comments. So our first case is a 15-year-old female who's living with her parents. She has a BMI of 16.5, so she's quite underweight. She's purging. She's not significantly depressed. And this would be a good candidate for Maudsley family therapy. Case number 2 is a 19-year-old female. Her weight is normal. She's engaging in eating binges every day. She's not significantly depressed, but has a social phobia and generalized anxiety disorder. Here we would consider supervised self-help or CBT or IPT, and we would also consider adding an SSRI if necessary for her anxiety. Case number 3 is a male. He has a BMI of 32, so he's significantly obese. He's engaging in binge eating behavior. He's also insomniac. He feels sad, guilty, doesn't enjoy life. His wife says he's down all the time. He at times feels like he'd be better off dead. He's not going to do well with self-help. What would we do here? And this would be an ideal case to use CBT and also a drug that will target, a drug combination that will target both his depression and his obesity. And that combination would be bupropion and naltrexone. Case number 4 is a 36-year-old female. She is mildly obese. She has bulimia nervosa with eating binges. She's not significantly depressed or anxious. She doesn't want self-help. And this would be a woman that would be a candidate for CBT And if additional treatment were desired for the weight, then I would suggest it should be considered. Topiramate and phentermine could be considered, as could LDX. Case number 5, this is a 17-year-old female. She has a normal BMI. She's binging every day. She also has self-cutting behavior. At times, she uses alcohol and cocaine. This would be the sort of patient where I'd seriously consider dialectic behavior therapy because of these associated problems that she has which need to be addressed. And she needs to be taught self-management, coping skills, deal with problems in her life. Number 6 is a 54-year-old male. He's quite obese. He has PED. He's hypertensive. He has dyslipidemia. He has fasting hyperglycemia, which suggests he has what's called prediabetes. And here is an indication for discussing bariatric surgery. The fire here is the weight, not the binge eating, and the weight and the hypertension and the other medical comorbidities. So this would be someone I would refer for a bariatric surgery evaluation if they would be willing to do that. So future directions for psychotherapy, I think we're going to see more development of technology-based approaches. We're going to see more on treatment matching. We're going to see more on psychosocial response prediction, which would be very useful. I also think we're going to see better work on biological response prediction, whether it's genetic or neuroimaging. And lastly, we need to be able to disseminate manual-based therapies better than we're doing now. Terry Wilson's been very interested in this, Denise Weltley has been, and other people have been as well. Future pharmacotherapy approaches, there are a number of possibilities. One is to manipulate energy expenditure in people that are overweight, which is something we can't do effectively now. Another is to manipulate hunger and satiety more effectively. A third is to manipulate the microbiome or the bacterial content of the bowel, which we don't have time to get into in detail. And lastly, biological response prediction with imaging and genetics. So what's the problem with psychotherapy and pharmacotherapy research in ED? Why are there so few studies in combination? Well, there's several reasons. One, the trials are expensive. They generally require very large sample sizes to be adequately powered. Usually you need multiple treatment arms, usually a minimum of 4. And so they're very difficult to pay for and to organize. 65% of research in the United States in biomedicine is paid for by industry. And drug companies are really not interested in combination trials. If I manufacture a drug, say for BED or BN, I don't want to study a combination because I'm not going to be able to patent that and market it. I'm interested mainly in pure drug trials. Also, NIH is increasingly not interested in treatment studies, in particular in drug trials. If a drug trial will benefit a pharmaceutical firm, National Institute of Health doesn't want to pay for it. And in the National Institute of Mental Health, which funds psychiatry research, there's a real focus now on what are called RDoC kinds of approaches, and they are not psychotherapy or pharmacotherapy treatment focused. Also, anorexia nervosa is a particularly difficult area. It's a relatively rare condition. It tends to be treatment resistant. A lot of pharmaceutical firms are frightened about anorexia nervosa patients. They know that they're medically ill and they may get sick, and so they stay away from anorexia nervosa. Also, the current administration is proposing cutting NIH funding, and that will have further profound negative impact on studies in this area. I'll close with a joke slide. Bad news, Phil, due to federal funding cutbacks, we can't afford to put your head back on. So some of us are quite worried about cutbacks in federal funding, which already are scant and far between. So I will stop there. Thanks so much for sticking with me, and I really welcome your comments and questions. Thanks very much.
Thank you, Dr. Mitchell, for that presentation. So if anyone has any questions, please just type them into the chat box, and I will ask them to Dr. Mitchell. Okay, so we have a question from Cheryl, and her question is, can you comment on the work the NRI is doing ICAT, I-C-A-T?
Right. Yeah, there's a pharmacotherapy that was developed primarily by Steve Wenderlich and others at NRI, but also at the University of Minnesota, called Integrative Cognitive Affective Therapy. It's a kind of a new stage in CBT development that adds a number of new methodologies, including technology-based support. ICAT has been used now in a BED trial and a BN trial, and it looks very promising. It was actually compared to CBT-E in one trial and did quite well. So ICAT is a good example of sort of a new generation of therapies that have CBT components, but have been broadened somewhat. And I think there are going to be some really interesting, exciting areas in that area. And ICAT, I think, is one that's the development of which is moving along quite well. So I think it's a nice therapy to know about if you're interested in that approach.
Okay, great. Does anyone else have any questions or comments? Yeah. A comment from Lauren. She was thanking you for your excellent presentation today.
Yeah, thanks, Lauren.
And if anyone else has any questions, please just type them in. Okay, it seems like there aren't any other questions. So, Dr. Mitchell, do you have anything else you would like to add?
No, I don't think so. Thanks very much for participating in the webinar.
Well, great. And that about wraps it up, everyone. And thank you again, Dr. Mitchell.
Thank you.
And I just wanted to tell everyone a reminder that our next webinar is scheduled on October 23rd with Dr. Andrea Garber. And she'll be discussing the topic of inpatient refeeding protocols. And you can find out more on the AED website. So thank you, everyone, and have a great day.